Thank you, Sangkun. Thank you, Kazu, for the introduction. And also thanks and congratulate Geza for the 30th anniversary. The topic this morning is in session of UGI and Bariatrics. We are discussing about controversial issue in bariatric surgery. My talk will be focusing on BMI above 50. First, before we get started, I think we have to talk or aim ourselves to talk on the same topics. What I would like to emphasize first thing is that if so, try not to use super obese. I think it's one part that we might be putting in concern that it might be a stigma for the patient. So what IPSO recommended is that just put it on the number BMI above 50, and it should be categorized into class 4 or class 5 obesity. So that is the consensus. For those, I will discuss more about the topics. But you can see that the endoscopic treatment might not be the choice. So I'm going to talk about what operation that we should do. So for BMI above 50, does it any differences from those BMI lower than that? So let's see. I think Kazu, this is a very prominent study back into year 2017 that it's been shown for obese for a BMI lower than 50. You might be seeing that the effect. I think for Luang gastric bypass, you choose is for very severe metabolic diseases. But anyway, you can see that the effectiveness of sleeve or sleeve plus DJB. But for BMI above 50, you may see the sleeve itself. It's showing lower of the BMI, but you can see is that not comparable to Luang or a sleeve DJB. So that I think it been shown even from other studies. Here it is. You can see that this is the comparison between Luang gastric bypass and sleeve gastrectomy. This is a systemic review and meta-analysis, even especially from 1 year after the procedure. You can see that for weight, it's been shown that sleeve might not be good enough. But actually for 24 months, you can see the effect might be lower. So what we have to see is that this is also might be the differences in terms of diabetes resolution, hypertension resolution. It's all favor on Luang gastric bypass size. This is obviously for dyslipidemia. In our center, back in 2014, we have reviewed our study, and then it also been shown the percent of excess weight loss is lower in sleeve gastrectomy group. What's about for long term? Because most study will show a year or 2 years. This is one of the long-term study, and been shown that you can see from BMI, the blue color representing sleeve gastrectomy started from 60-something for the BMI, and it's coming down even above 40. So it's a concern. But anyway, this is for long term. Then surgical strategy for BMI above 50, what the current surgeon decisions. So I think all surgeons been alert, been educated by the studies. But what they choose, this is the online questionnaire-based survey in 2022. So even if we know that sleeve might not be good enough in terms of average weight loss and diabetes. So you can see that number one is still sleeve gastrectomy. This is a survey, what should we choose? And it is saying that 27% will choose sleeve gastrectomy. Luang gastric bypass is interesting. You can see the standard, and also the long alimentary limb, which is the alimentary limb longer than 1 meter, or long BL pancreatic limb more than 1.5 meters. So that altogether is about 26%. So you can see that even in the study have been shown that effectiveness of sleep might not be that good, but the surgeons who attend this survey also saying they might choose sleeve gastrectomy. Now in the specific group of patients, age under 18, you can see that 61% will choose sleeve gastrectomy. On the other hand, elderly patient, so they said 54% will choose sleeve gastrectomy. So even if the evidence has shown that already, but what behind we should follow on this survey. So which procedure? So number one, we know that sleep might not be good enough. Number two, in the past, lumbal gastric bypass has shown more effective. Number three, we have seen that surgeons still, 27% still choose sleeve gastrectomy. So then what it is on this study, you can see that it is from Turkey. They try to show that even BMI 56, they can be going down to 33 after 2 years. So I think a lot of studies are still coming up. If it's not comparing to other procedure, you can see most of the patients also successful from the treatment. This is to compare to see the successful rate. If you use estimate weight loss more than 50, you can see that at 2 years, 92%, or you use BMI below 33, you can see that 60% also get to that point. Means sleeve gastrectomy in BMI above 50 is still effective. At least half of the people get to the point that they should go. So that coming up to us is that we cannot say sleeve is not working on BMI above 50. This is a systemic review for another procedure, which is OAGB. So I think in Asia and also in some part of the world, OAGB is the most common procedure. Absolutely, it's also showing that OAGB is getting better than sleeve gastrectomy. On the reminder that sleeve is also effective in some, at least more than half of the people would do. I'm going to touch a little bit on this study. This is the randomized control trial, a good study, and follow up for 12 years after the procedure. The random, the 60 patient BMI between 50 to 60. And what you can see here, dual switch absolutely showing a very good result. You can see that significantly lower the mean BMI, but also coming up with some additional to the procedure itself. You can see from here, especially for bone metabolism, it's showing that for the DS, the dual switch have been shown very much exhausted in bone metabolism. So this is also coming up to choices that you're going to choose for the patient. You have to talk to the patient, you have to discuss with the patient, you have to follow the patient. Then it would be beneficial from the procedure without any serious complication. But in this study, it's been seriously saying that 10% of the people of DS need to be revised because of malnutrition. And they concluded that Bureau Pancreatic Division, it shouldn't. This is a randomized control trial. At the end, they said, okay, shouldn't say that it's better than lumbal gastric bypass, but they mentioned at the end that they do, at that time they did the common channel less than 2 meters. So I think it's still, we need to, when we look at the study, we need to see in detail about the procedure, how long the limb length, how long the common channel, because it's also it's available in that part. And also all techniques still on the process of adjustment for the appropriate one. So another question is that BMI above 50, do we need to do something specifically, especially? Should we prepare the patient before? Should we have the patient follow some conventional treatment before? This study coming last year very nicely. They choose the patient and they categorize. This is an observational study. some patient who came to the center might not have the treatment, but all of them have the conservative treatment. And the question, what this study would show is that those who try conservative treatment, which very much in the, restrictive in nutritional consultation, dietary lock, and also energy deficit of 500, also engage in the exercise activities. Interestingly, you can see from here, for those who under the conservative study, it's shown no. This is from 6 months, no weight loss, I mean, in the DASH group, but actually you can see that some would have some weight loss, some would be, even increasing in weight. But for a study group, which is the surgery, you can see that 6 months they can lose 33.6. This is not the point. We know that it will be absolutely better in the surgical group. But even weight is not changed, but you can see from their detail in metabolic, you can see that the blue and the green representing remission or improvement. Weight doesn't go down in average, but I mean the resolution has been shown. This study, what I would get from this study is that now come those groups who are under conventional treatment, but they cannot successful, they switch to surgical treatment. Now the study, this, what I learned from this study is that you might not need to, from this study, to prepare the patient very restrict before the operation, because you can see that after the treatment, what is being shown here, is that even it's better in those patients who come for the treatment, prepare, optimize, and go proceed to the procedure without any 6 months before the procedure. I think it depending on the reimbursement system in Germany that they do need to have this type of preparation before the surgery. Interestingly, this is to see the step or the stage treatment, actually step treatment, comparing to surgical first. What we are seeing that it's similar in complication, except the stenosis. I don't know why on those step treatment they have shown significantly higher incidence of stenosis. Now come to the big data, how the large data would show. Thanks the Scandinavian Obesity Surgery Registration, SOS registration, you can see that they have 83,000 patients in the study. They categorize into 4 groups, and then we'll see what's happening in here. You can see the BMI range, and then this is a study. Actually, what we have seen here is that you can see they compare Udomsawaengsup gastric bypass, sleeve gastrectomy, and BPD-DS. This is the long-term result for at least 5 years. So what you can see from here, you compare sleeve gastrectomy, Udomsawaengsup gastric bypass, BPD-DS. We cannot say that sleeve is not working, or we may be saying that BPD-DS is very nice. You can see that even the line, representing the blue line is the BMI, actually the green and the blue, it's 50 to 60 and 60 to 70. So to me, I try to translate this study to this successful rate. So we might need to categorize in detail BMI above 50. So you see on the green and the blue line. If you see on sleeve gastrectomy, even the BMI between 50 to 60, the green, you can see that even if BMI below 40 is the point that the patient should go, they're also having a successful rate very high. This is very interesting. So that, and also, what I would like to see inside here, it's 2-year total weight loss. You can see that it seemed to be very nice in BPD-DS, 43% of total weight loss. 33.9% for lumen gastric bypass, and also 28.9% for sleeve gastrectomy. So this is a study to see from 2-year weight loss. And for 5 years, even you can see that the total percent of total weight loss is still maintained. So I think this study insight very much us that even all procedure would show beneficial effectiveness, yes, significantly different. But as I said, we need to keep in mind what term of successful that we would define. Thank you, Professor Kim. Here, a study from Korea, try to see the local data. It seems to be not too many, but what we have seen here for BMI above 50 in Korea population, sleeve gastrectomy used to be, a long term, and then it can see from 50 something, it's gonna be sleeve, but then they put sleeve plus, which is the plus is DJB or PJB. DJB they choose is for severe diabetes. So what I would like to translate from this study is that even sleeve also working, but sleeve plus, I think we do need to have more information. For those Luang and the studies procedure, you can see that it's very much successful in terms of the success BMI lower. And this is to show the percent of total weight loss. So sleeve gastrectomy, the blue line, you can see that it's also having about 20 to 30% of the total weight loss. Sleeve and SADI is also showing better. So I think it's also going with the global data. And if we categorize at 20% of total weight loss at the success rate, you all would have a successful weight. So I think it's very much in this part. Talking about sleeve plus procedure, I think it's so many varieties. Some study will show initially about DJB, but right now we have more and more study to more procedure and more indication. I'm not doing much in that part because it's so much varieties. But anyway, it's been showing from this study that sleeve plus even better than Luang gastric bypass. But this is JJB or DJB. So I think when we try to compare, we need to look in detail what procedure and what the arrangement, alignment of the bowel, length of the bowel, length of the common channel. So ladies and gentlemen, I think it's been shown several studies to show that comparing to Luang compared to sleeve had been shown, and then other procedure comparing to Luang, some study would show better than Luang gastric bypass. So ladies and gentlemen, I conclude this part of my study is that in metabolic and bariatric surgery, it's safe and effective for sure for even BMI above 50. Sleeve gastrectomy used to be thought that it might not be working, but it's been showing. What we would like to emphasize is that we have to aware of having a higher suboptimal response, especially for BMI above 60 from the big data that we have seen. So that we need to discuss with the patient. If the patient feel very comfortable with sleeve gastrectomy, we also need to mention that the higher incidence of the suboptimal response. Luang gastric bypass is recommended because they've been studied for a long time, especially for the reflux problem. So the switch actually has been shown the most effective, but actually the consideration should be going on long-term nutritional management and nutritional deficiency condition. Sleep plus procedure, I would say it's coming up, and it would be added into the choices of the treatment, especially some procedure. We need to look in detail is procedure itself. And I would say that stage operation might not be routinely recommended from that study, that you might be optimize the patient and you might be beneficial from going straight to the procedure. Last but very important is that teamwork is very important, and the patient adhere to the program might be crucial to determine the result. Ladies and gentlemen, my colleague here, I would like to take this opportunity to invite all of you to Bangkok, Thailand next year, September 23, which is the pre-congress, and 24, 25, the main congress for Asia Pacific Hernia Society meeting in Bangkok. Thank you very much.
Good morning, everyone. I'm Wonjun-seo from Korea University, Guru Hospital. It is a great honor to present here at KSCRS 2026. The title of my presentation is Choosing the Right Procedure for GRD-prone patients. And not like prior or other remaining questions, my topic is is not a difficult question to answer for many expertise in this room. So I have nothing to disclosure. And obesity and GRD are closely connected. Studies show that up to 50% of bariatric surgery candidates report baseline GRD symptoms at the time of evaluation. The overlap between severe obesity and gastroesophageal reflux disease is significant. If we choose the wrong procedure for a GRD-prone patient, we risk postoperative complications, worsening the reflux symptoms, and the need for revisional surgery. Therefore, GRD is not just one item on the preoperative checklist. It is a critical factor that determines which procedure we should offer. There are three key mechanisms by which obesity causes GRD. First, elevated intra-abdominal pressure. Increased visceral fat creates a mechanical pressure gradient that physically weakens the lower esophageal sphincter. Second, anatomical disruption. The prevalence of hiatal hernia is significantly higher in obese patients. This directly weakens the crural diaphragm, which normally acts as a second barrier against reflux. Third, altered motility. Obese patients show higher rates of transient ADS relaxation and delayed gastric emptying. So, before the surgery, these pre-op evaluations should be considered for the best postoperative outcomes. The first, upper endoscopy. This is mandatory in GRD-prone patients, actually all of the morbid obesity patients. We need to rule out erosive esophagitis and hiatal hernia before surgery. Positive findings can and should change our surgical plan. Second, high-resolution manometry. This is essential when we suspect a prior motility disorder, and this HLM should be performed when symptoms are atypical or when the patient reports difficulty swelling. Third, 24-hour pH impedance testing. This is the standard test for objective GRD measurement. It quantifies acid exposure time and matches symptoms with actual reflux events. Fourth, CT scan or contrast esophagogram. This study is useful for mapping the size and anatomy of hiatal hernia, and many guidelines, the contrast esophagogram is recommended, but some countries like us, the CT scan is highly accessible, so it could be replaced. This approach is well supported by the 2022 ACG clinical guideline on GLD. The ACG makes a clear statement: relying on clinical symptom alone is insufficient. GLD must be evaluated using objective measurement before any surgical intervention. The guideline also recognizes that anti-reflux bariatric surgery, specifically ROIGB, should be actively considered as a primary long-term treatment option for patients with objectively confirmed GRD. The ACG framework supports the concept of objective evidence-based evaluation as the foundation for surgical planning. The International Society of Disease of the Esophagus positions statement as important details for our bariatric patients. They showed 10 statements for importance of preoperative endoscopic workup. The first statement is that the all bariatric patients should perform endoscopy, not limited for symptomatic patients. In summary of other statements, The ISDE strongly recommended pH impedance monitoring for patients with atypical GLD and HRM when a motility disorder is suspected. This preoperative evaluation formed the foundation for safely choosing between sleeve gastrectomy and RUIGB. The ASMBS published a clear position on the endoscopy in their 2021 position statement on before and after bariatric surgery. For preoperative endoscopy, the ASMBS consider EGD is essential for detecting erosive esophagitis, hiatal hernia, and Barrett esophagus before surgery. Positive findings frequently change the surgical plan. This is not just a screening step, it directly impacts on the decision. For postoperative surveillance, the ASMBS strongly recommends follow-up endoscopy in post-sleep patients, and the critical point is here that regardless of whether the patient has symptoms, their recommended interval is after 3 years post-sleep. The primary goal is early detection of silent GLD and prevention of progression of Barrett or malignant progression. The 2020 EAES clinical practice guideline update, endorsed by both IPSO and EASO, provides additional international consensus. In this guideline, sleeve gastrectomy is firmly established as a highly effective and independent metabolic procedure. Its efficacy for weight loss is not in a question. However, due to its anatomy, the persistent risk of long-term GLD worsening means sleeve cannot be applied uniformly to all patients. For patients with significant pre-existing GLD, RUIGB is the safest and most rational evidence-based choice. Across the major international societies, RUIGB is the gold standard for GLD-prone bariatric patients. With postoperative anatomical superiority, RUIGB prevents both acid and bile reflux into the esophagus. It achieves this by completely separating the food stream from bile and pancreatic secretions. In addition, the creation of a small low-pressure gastric pouch with rapid emptying means there is less acid volume and less mechanical pressure driving reflux upward. RUIGB resolves existing GLD symptoms in the large majority of patients, while also providing excellent long-term metabolic benefits. Now, I will present the key randomized controlled trials for the evidence. This is the best trial, the bypass equipoise sleeve trial. This is one of the largest head-to-head RCT comparing sleeve gastrectomy and RUIGB. 1,722 patients were randomized across 23 hospitals in Sweden and Norway. The primary outcome was perioperative complications at 30 days. The finding is there was no significant difference between sleeve gastrectomy and RUIGB in either any adverse events or serious adverse event. The odds ratio were 0.71 and 0.63, respectively, both non-significant. This result is assuring. It means when we choose RUIGB over sleeve gastrectomy for GLD-prone patients, we don't need to worry about the great perioperative risk. And the most important long-term RCT data comes from the sleeve test trial. 240 patients were randomized at 3 hospitals in Finland to find out 10-year excess weight loss in both procedures. For weight loss at 10 years, sleeve gastrectomy achieved 43.5% excess weight loss compared 51.9% for RUIGB. The between group difference was 80.4% and statistically significant. At 10 years in sleeve test trial, objective endoscopic esophagitis was present in 31% of sleeve gastrectomy patients compared to only 7% in RUIGB group. That is a 4-fold difference. The p-value is less than 0.001. PPI use was also significant. In sleep group, 64% versus 36%. And reflux symptoms were reported by 80% of sleep patients compared to 54% in RUIGB group. At 10 years, 1/3 of sleep patients have objective esophageal injury, nearly 2/3 require PPI medication, and 4 out of 5 report reflux symptoms. These are numbers that must be shared with a patient during perioperative counseling. The Assembles trial from Switzerland is another major RCT in bariatric surgery. 225 patients were randomized across 4 bariatric centers. The primary outcome was excess BMI loss at 10 years. Again, RUIGB was superior for weight loss, 65.9% excess BMI loss versus 56.1% for sleeve gastrectomy. The difference was statistically significant. And in this trial, they showed that the time to conversion curve for 14 years. The sleeve gastrectomy curve dropped sharply from the early years onward. By the end of the study period, 29.9% of sleeve patients required conversion to a different anatomy. In the RUIGB group, the conversion rate was only 5.5%. The reason for conversion in the sleep group is that reflux was the number one cause, 46.9% of all conversions. Suboptimal weight loss was second at 28.1%. A combination of both spectra accounted for 18.8%. Nearly 1 in 3 sleep patients required a second major operation, and reflux was the dominant driver. This conversion rate represents a substantial long-term burden for both patient and surgical team. This multi-center cohort study from 5 high-volume centers in France and Italy performed systematic endoscopy at 5 years post-sleeve gastrectomy, regardless of symptoms. GRD symptom increased from 22% before surgery to 76% at 5 years. Objective esophagitis increased from 10% to 41%. PPI use increased from 10% to 52%, and many patients in this cohort with objective. This confirmed the prior ASMS recommendation. Surveillance endoscopy after sleeve gastrectomy must be performed regardless of symptoms for 3 to 5 years. And this brings Western population to the most serious long-term concern, Barrett esophagus. This meta-analysis analyzed 19 studies with 2,000 patients to evaluate the risk of de novo Barrett esophagus after sleeve gastrectomy. The pooled rate of de novo Barrett esophagus was 5.6% with a mean follow-up of 2 to 11 years. The key relative risk data is that the risk of erosive esophagitis is 3.37 times higher after sleeve gastrectomy. Risk of clinical GRD symptoms 3.32 times higher, and risk of requiring chronic PPI use is 3.65 times higher. And complementary meta-analysis published in 2021 showed interesting data. This meta-analysis performed in 10 studies with 680 patients and up to 10 years of follow-up. They show that the risk of developing erosive esophagitis increases linearly by 13%. The pooled de novo Barrett esophagus prevalence is 11.6% every year after sleeve gastrectomy. And there was zero correlation between the presence of Barrett esophagus and patient-reported symptoms. All of these evidences show that the procedure of choice for the GRD-prone patient is the RUIGB, and in patients with post-sleeve gastrectomy, the endoscopic surveillance is mandatory, even in completely asymptomatic patient. The one less procedure requires discussion is one anastomosis gastric bypass or OHB. OAGB has grown rapidly in recent years due to its technical advantages, a single anastomosis instead of two, shorter operative time, and strong metabolic outcomes. These are genuine benefits that explain its increasing adoption. However, the critical question is, does OAGB control GRD as effectively as RYGB? In 2024 meta-analysis of 9 RCTs involving 643 patients provides a direct answer. Overall GRD risk with OAGB was 3.14 times higher than RYGB, and de novo GRD risk was 5.65 times higher. In OAGB, the sleep component is still preserved, and the pressure of the LES is not better than many surgeons expected. The conclusion is clear. Extreme caution is required when considering OAGB for patients with pre-existing GRD. So, in conclusion, today's evidence leads to 4 clear messages. First, the mandatory or pre-operative workup. Symptoms are unreliable. Half of all bariatric candidates have baseline GLD, and many more have silent reflux. Second, RYGB is the gold standard of care for GRD-prone patients. The anatomical advantage is clear, and 10-year RCT data from both SLEEPS and SMBOS confirms superior reflux control over the long term. Third, long-term sleep gastrectomy risks are real and cumulative. A 30% of conversion rate at 10 to 14 years, a 13% annual linear increase in esophagitis risk. The fourth, silent disease required active surveillance. Endoscopic follow-up after 3 or more years post-sleep is mandatory regardless of symptoms. The surgical decision is not only about the weight loss result, it is about protecting patient esophageal health for the next 20 years. Thank you for your kind attention.
Thank you very much. So I've been given the task to talk on timing of revisional surgery for weight regain and long-term complications. I have no disclosures to make. I hope through the presentation today we'll be able to see what weight regain really is and surgical non-response is, pin down some underlying mechanisms for failure, review indications and timing for revision, compare the early and late revision surgeries, and propose a practical stepwise algorithm. So here it is. If you look at revisional metabolic surgery, if you have a good practice, it's suffice to say 1/4 of your practice is going to be revisional surgery. And of this, the most common indication is recurrent weight gain. That's the, if so, current status. It is called recurrent weight gain. And the late complications of this recurrent weight gain is metabolic disease comes back, quality of life becomes poorer, and nutritional complications kick in. What is not so good about revisional surgery is, first of all, the patients don't lose as much weight as the primary surgery. 2, it is fraught to higher complication risk, and that's why should be done in centers of excellence. Now, this is IFSO's current consensus statement, and it basically says that if a patient gains back about 30% of the initial weight loss, that's total weight loss, then it is considered recurrent weight gain, which means that below 30%, people would say that this is a physiological weight gain because the body is trying to reset its set point, or worsening of complications at what if so agrees. Total weight loss of less than 20% is suboptimal weight loss. They have done away with the terminology of what is called poor weight loss and calling it suboptimal weight loss. And why do we revise procedures? We revise procedures because there was anatomical aberration and we are going to correct that anatomy. They convert to other procedures because there is failure to achieve the outcomes that we wanted, or reversal, for example, severe malnutrition or other medical needs that the patient may have is what triggers us to do these procedures. Why do people actually fail their outcomes, as we would say, or regain their weight? There are some anatomical considerations, there is physiology behind it, and obviously behavior therapies are something that's behind it. Anatomically, any pouch over time, nature in human beings is pliable. A sleeve can dilate, a gastric pouch can dilate, a esophagus can have a compensatory dilatation over time. So if you do a sleeve on a 32 French bougie and the patient gains weight, then be assured that the esophagus has dilated to form a stomach of its own to store the food. The natural reservoir for food storage is the fundus. When you take it out, the body will compensate. Obviously, reflux is one of the reasons, because these people, because of the symptoms, tend to go and start drinking high-calorie drinks or other things to obviate the reflux in these patients. Hormonal adaptation. We think that after a sleeve gastrectomy, the ghrelin levels dip, people lose weight, lose fat mass, but the ghrelin levels from the other sources starts coming up after time. There is GLP-1 adaptation as well. So, and metabolic compensation, the body will slow its metabolic rate, make the muscle more efficient in using energy, thereby conserving the body for making sure that the body has enough energy resources. Behavioral attitudes, night grazing, watching a movie, eating things you must munch, sitting down in the office, doing work, corticosteroids high, stress high, you must munch, drink coffee, hyper response, you must munch, all these things. And then you see on the last line is poor follow-up. Yeah? Why? Because it deprives the patient of an early intervention, an early counseling. So that's why people regain weight. I wanted to touch upon this to let the audience know that it is very common within the first to 5 years for people to have physiological weight gain. And as you can see data, as many as close to 1/3 of patient population we treat would regain about 25% of the lost weight in the next 7 to 10 years. Yeah? So how can you then and me prevent this progression? It is by managing malnutrition, GERD, and diabetes recurrence in these patients that we can help these patients. Now, let's look at when does the weight regain actually happen. If patients are not adherent to diet, you've done a sleeve on them and they go on a liquid diet, then there you are, 1 to 3 years, their weight starts coming back. It deceives the whole purpose of the procedure. Gastric pouch dilatation seen at 3 to 5, sleeve at about 3 to 7. The gastrojejunostomy that we talk of, 1 centimeter being restrictive, keeping the food in the pouch, dilates at 2 to 5 years, and fistula from 1 to 10 years is what we know. So when should we intervene? The timing is actually not fixed. It is personalized. And what should we put into consideration if we are going to revise these patients? We need to look at the rate of weight regain, because that will give us an idea as to what the cause is. If the symptoms of complications are severe, if we have tried non-medical management and it has really run out of options, the nutritional status, patients go malnourished, you need to be aware, and we need to then balance the risk and benefits of the offers we need to make to our patients. Here is my personal thought of what early revision and delayed revision should look like. At early revision, you have patients with lower BMI. You have fewer adhesions and intra-abdominal complications, better metabolic rescue than a delayed intervention, and shorter operating times, because the patient is relatively small in size. At delayed revision, you generally have a higher risk because of pure BMI and what we have just listened a while ago. They have advanced malnutrition. Their quality of life has deteriorated. They may not be ambulant or other things. And higher complication rates is what we see. So delay in converting functional revision or going to salvage surgery is the option. So what are the timings? Early is less than 2 years, usually behavioral causes, and I would caution that we should avoid early revision in this group, put them on medical therapy, because even if you do a second procedure, the outcomes are not going to be any better. However, if there is a technical failure, then yes, it makes sense to offer the surgeries. We have seen people leaving behind large funduses, having huge gastric pouches, and so those are technical failures. Between 2 to 5 years, that's the most common window that we would revise our patients, study the surgical anatomy very carefully, and if you have failed a structured lifestyle and medical therapy, then surgery is a recommendation. And generally beyond 5 years, it's multifactorial, and again, mainstay is medical therapy. So, as I said, within 2 years is from index surgery is what it is called early revisions, generally offered for nutritional complications. I have a 6% revision rate for OAGB for surgical complications, including very bad reflux, bad malnutrition, then after nutritional therapies, optimization in these patients, we need to give pharmacotherapy, which is the mainstay of therapy for weight regain these days, knowing that eventually it may not succeed because compliance of patient to the medical therapy is poor. Let's get it right. The drug is not bad. The drugs are excellent. They are like diabetic drugs. Why do patients with diabetes not succeed in preventing complications? It's not that the drug is bad, it's patients are not compliant to drug and advice. And it's the same case in obesity and a chronic disease. You have endoscopic options and especially justified when there is reflux and anatomical abrasion. So suspected technical difficulties or technical glitches are large gastric bypass pouches. So we were just hearing people doing 50 BMI gastric bypasses. For those of us who have met with Asian patients, it's not an easy task to do an Asian 50 BMI gastric bypass. Our livers are huge, our intra-abdominal fats are dense. Just getting that rule loop from below anticolic up to a good small gastric bypass pouch, it's not the easiest thing in the world to do. It is fraught with a lot of marginal ulcers. So yeah, we can talk about that. Large stomas. Irrespective, you look at data from OAGB, you look at data from SASI, you look at data from SADI. The moment the aperture goes beyond 2.5 centimeters, weight loss starts becoming poor. Okay, anatomically clearly faulty and non-surgical failures are what we do. Most recommendations are for timing. When should we do it? We should do it when the weight regain has stabilized. Yeah, do not do these interventions at time of rapid regain, and usually leave them to stabilize their weight at 3 months. According to the authors of this paper, allow for optimization and identifies true anatomical or behavioral causes, which should be the premises of the investigation in the very first place. These patients of revisional surgery should go through an MDT assessment seen by a nutritionist, a psychologist, because a huge component ultimately you will find are those patients who are stressed, anxiety, depression, binge eating, night grazing. All of these are treatable through behavioral therapies. Exercise tolerance, optimize medical losses that you can see like GERD and all those. give a trial. If they respond, maintain them on GLP-1, and then there are endoscopic measures that you can do. If we look at outcomes of revisional surgery for weight loss, the effective weight loss achieved is about 60 to 70%. Sleeve to OAGB at 12 months has the highest, 68%, but look at the 30 days morbidity, anywhere between 7 to 15%, and it is not without mortality. To me, mortality happens only once. For that patient and that family, it's an index event, right? It may be 0.5, half patient. So what am I saying? I'm saying out of 200, one patient will die. That's not something that should be taken lightly for a benign disease, in my opinion. So let's look at long-term complications in the last few seconds. Severe GERD, generally seen after sleeve gastrectomy. We just heard a great talk on it. And when would I offer if they're not really coming up with medical therapy? Proton pump inhibitors are not doing well. Patients is having difficulty moving food down, or the patient is not willing to take medications like doesn't want long-term medications. Marginal ulcers seen in RYGB, OAGB, just beyond one failure, at 1 year failure. Generally, I would say failure of medical therapy or complication. Before I came, I did a patient of mine who had an OAGB, had a perforated marginal ulcer. At the same time, I converted the patient to Roux-en-Y gastric bypass. So sometimes you just have to bite the bullet and do it. Gastrogastric fistulas, in the very first place, they should not happen. If they do happen at the time of diagnosis, you got to treat them. Slippage and band erosion at the time of diagnosis, optimize the patient. Chronic malnutrition, there is ample data, most of the data coming from OAGB, optimize them, admit them, make sure that you put them on total parenteral nutrition, get their physiology in order, get their micronutrients in order, have them put some weight, otherwise you will lose your patient. Patients would die upon you. There's a huge Iranian series that talks about this if you want to read into literature, and generally should be that. Internal hernia, immediately once you diagnose it, you got to go back in and treat these patients. Functional bile reflux, if medical therapy fails, ASAP, strictures or dysphagia. I've seen patients with sleeve strictures. Their physicians have told them, oh, it's okay, it will be all right, you're doing well. Ultimately, they will need a surgery, but you can revive them much earlier because the complication is not going to go away. Protein calorie malnutrition after failed medical therapy, giving them amino acids, giving them protein replacements, especially common in our part of the world. We have a lot of vegetarians where we find it very difficult to replace supplement proteins. Micronutrient deficiencies, especially fat-soluble A, D, E, and K, and lipid disorders. Dumping syndrome. I do not know how many of you have had exposures to OAGBs. My dumping syndrome rate is about 20% in OAGB. That wide anastomosis I spoke to about, that's like 4 centimeters, doesn't help the cause. So something close to 3 is optimal, which gives you close to a 45 French or a diameter of about 1.25 centimeter ostia is more than enough. Hypoglycemia, again, sort of related to the first phase of dumping syndrome. You try A-carbos, you try low carbohydrate and complex carbohydrate diets, and if they fail, then for these complications, you got to reverse or change your procedure. So really, the decision-making tree is detect complications early and investigate, is this my doing or is this a surgeon's doing? If the answer is no, then optimize medically. And if you still can't, then you select a revision deliberately. You say, no, this is not going to solve. I counsel you, I recommend you go through a revisional surgery. Otherwise, it will be difficult to live. And weight issues alone, generally medical therapy is suffice, and if it's weight and anatomy issues, then consider early revision. So essentially take-home messages today: weight regain is accepted and it's not exceptional. This is the physiology of chronic disease. It scales up from lifestyle to medication to endoscopy therapies to surgery and revisional surgery. So this is chronic therapies. Revision should be part of chronic disease strategy and not just one in an episode. So I tell my patients, this is a chronic disease, you've got to keep coming back. Okay? Distinguish technical failure, all right? Do not hide your head in the camp like a camel and think everything outside is okay. Let us own the care we provide to our patients. Timing is the single most modifiable risk factor. Most people recommend wait till weight stability and treat medically till it arrives at a surgical decision. Long-term complications would generally mandate an early intervention, as I just showed. Early revision equals to better outcomes and lower risk for our patient. So ultimately, it's the ego of a bariatric surgeon that we need to nullify and say, it's time to go back in. With that, thank you very much, and I'm very happy to take it.
Thank you for your kind introduction. I will be discussing a critical dilemma we face in our daily practice when and what anti-obesity medications should we use. I have no conflict of interest to disclose. Today, we will focus on two key questions: when to use anti-obesity medications and what to choose. We will also discuss two major challenges: muscle loss and drug cost, to achieve the best patient outcomes. Obesity management has changed dramatically. We are moving from surgery alone to a combination approach. We are currently facing a GLP-1 tsunami. From 2019 to 2024, the prescription of GLP-1 for obesity increased by nearly 600%. A recent paper noted that bariatric surgeries declined by 42% relatively to the surge in non-surgical obesity management in US. In this hybrid era, anti-obesity medications are no longer our competitors. They are our partners. Now, the main dilemma is when do we use them, and which ones should we choose? To answer the when, we can categorize the timing into three phases: neoadjuvant, early adjuvant, and rescue therapy. Let's begin with neoadjuvant anti-obesity medications. We are seeing a massive surge in prescribing GLP-1 before bariatric surgery. Utilization of GLP-1 prior to bariatric surgery has increased threefold for 5 years. This study demonstrates that neoadjuvant GLP-1 treatment significantly enhanced preoperative weight loss prior to sleeve gastrectomy. Although this initial weight loss advantage was not maintained in the postoperative period. Preoperative GLP-1 treatment effectively reduced liver volume. This optimizes the surgical field, shortens operative time, and lowers complication risk, ultimately making the procedure significantly safer. Interestingly, preoperative GLP-1 helps with initial weight loss, but they don't always guarantee better long-term postoperative results. This is why finding that the optimal hybrid strategy remains the next big challenge for our field. Next is adjuvant therapy. Obesity is a chronic disease, and we know that nearly 30% of our patients experience suboptimal clinical response or recurrent weight gain over time. Why does recurrent weight gain happen? This study reveals a critical adaptation. Patients who regain weight fail to secrete sufficient GLP-1 and GIP after meals. This physiologic deficit is exactly why combining surgery with GLP-1 pharmacotherapy is the logical next step. This is why adjuvant therapy is no longer an option, and it is a vital bridge to long-term success. By doing so, we effectively fill the hormonal gap with GLP-1 medication. Why does GLP-1 work so well after surgery? Here's the theory. Surgery increased GLP-1 after meals, while GLP-1 medications raise basal levels throughout the day. By combining the two, we achieve all-day metabolic coverage, creating a powerful synergy that surgery alone cannot reach. This is a reassuring finding. We often wondered if the previous metabolic surgery might alter our patient's response to medication. However, this study proves that post-bariatric patients respond to GLP-1 medication just as effectively as non-surgical patients. Although this RCT was limited by its short-term follow-up, the result shows that adjuvant GLP-1 therapy leads to greater weight loss. It suggests that adjuvant GLP-1 could be a promising strategy, warranting further large-scale long-term studies to confirm its clinical role. Moving on to the rescue therapy, the most researched area in this field. Let's look at the evidence for suboptimal clinical response or recurrent weight gain and answer two key questions: when to start and how long to treat. The rapid rise of GLP-1 therapy is reshaping our field. As you can see, the volume of primary metabolic surgeries has plateaued. Even more notable is the trend in revision surgery. Post-pandemic, we have not seen the expected rebound in surgical revisions. This suggests that more patients and clinicians are now choosing medical therapy as a first-line rescue therapy. This RCT showed the effectiveness of liraglutide in patients who had inadequate weight loss and at least 1 year after surgery, with a weight loss of more than 8% when used for 6 months. Another RCT showed that liraglutide can be used for the improvement of type 2 DM by showing significant reductions in hemoglobin A1C and weight loss in patients with type 2 diabetes who persisted 1 year after surgery. Several recent RCTs have confirmed that GLP-1 medications are both effective and safe for the patients who have suboptimal clinical response or weight regain. While there is no consensus yet on the optimal timing to start medication after surgery, we know that the difference in initial weight loss can lead to difference in the long-term weight loss. This study provides a compelling rationale for early intervention. It demonstrates that initiating anti-obesity medication earlier in the post-operative period leads to significantly greater long-term weight loss. Short-term weight loss is just the start. Since GI hormone adaptation persists, we must shift our goal from simply losing weight to sustaining it through ongoing metabolic support. What happens when we stop? Data consistently shows that discontinuation of GLP-1 leads to weight regain. Multiple meta-analyses demonstrate that long-term use significantly beyond 1 year yields superior weight loss outcomes compared to shorter durations. Simply but the longer we maintain the therapy, the better the result for our patients. Regarding safety, the data is very encouraging. The incidence of side effects in post-bariatric patients using GLP-1 therapy is comparable to that of non-surgical patients. The key factor for minimizing this side effect is timing. Data shows that the risk of side effect is significantly lower when we initiate GLP-1 therapy 12 months after surgery. Now let's move to the next question. What agent should we choose? Here you can see various FDA-approved obesity management medications. Liraglutide is the first GLP-1 receptor agonist, and now we are using more powerful medications such as semaglutide or tirzepatide. As we all know, in non-diabetic patients with obesity, tirzepatide has shown superior weight loss compared to semaglutide. Importantly, this efficacy holds true for our post-bariatric population as well, showing similar benefits. Interestingly, real-world data reveals different titration patterns. For tirzepatide, 56% of patients are maintained at lower doses. In contrast, only 31% of semaglutide users remain at lower doses, meaning most semaglutide patients require higher titration. Additionally, about 10% of these patients are using non-incretin anti-obesity medications in combination. This real-world snapshot of a combined therapy is something to keep in mind when managing your patients. Finally, let's address the sarcopenia and cost. Looking at tirzepatide, we see a body composition changes similar to general weight loss. About 75% of fat mass loss and 25% lean mass loss. This pattern is consistent with what we observe in placebo groups. However, when we compare this to metabolic bariatric surgery, the results are quite different. Surgery consistently shows a superior body composition profile, achieving significantly higher fat mass loss while better preserving lean muscle mass. Therefore, when using GLP-1 long-term, we must carefully monitor for sarcopenia. To address this, exciting research is on the way, such as combining semaglutide with bimagrumab. This combination aims to selectively burn fat while protecting our lean body muscle mass. As we all know, metabolic bariatric surgery remains the gold standard for long-term weight loss. Beyond the clinical benefits, it is economically superior. After just 2 years, it translates into approximately $12,000 in cost savings compared to GLP-1 medication. According to a 2024 ASMBS analysis, the cumulative cost of GLP-1 therapy surpassed the total cost of bariatric surgery within just 1 year. Unfortunately, this heavy financial burden is the main reason why we see so many patients stop their medication in real-world practice. Interestingly, even though GLP-1 demonstrates superior efficacy and safety compared to non-incretin anti-obesity medications, the latter are still more frequently prescribed. This paradox is something we should carefully consider when selecting treatment options for our patients. Traditional anti-obesity medications work through distinct pathways compared to GLP-1. Because of these unique mechanisms, combining them can create a powerful synergy effect, potentially maximizing our patients' weight loss outcomes. Finally, remember that the traditional medications have been proven effectively for postoperative weight loss in old studies. Given their economic efficacy, they can serve as a practical maintenance strategy to lock in our patients' weight loss long term. This algorithm summarizes our strategy, assess the timing, evaluate the post-operative anatomy, monitor muscle mass, and consider the patient's financial reality. To wrap up, let me share 3 key takeaways. First, the hybrid era isn't about choosing surgery or medicine. It's about maximizing their synergy. Second, strategic early intervention is our most powerful tool to address hormonal adaptation. Finally, by managing sarcopenia and cost through smart combinations, we can offer our patients a truly sustainable long-term solution. Thank you.